Good afternoon, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. Today, I will be conducting a quiz, and based on that, we shall proceed. Right? So, I'll discuss the questions too with you all. You all will be given 1 minute each to give answers to the question, and I will discuss the questions with you all too. So, Unacademy is one of India's largest online learning platform, where you can crack NEET PG with us, where you get plus subscriptions, access to unlimited live and recorded courses, and all these are from India's best educators. Now, what will you get out of Unacademy? Basically, Unacademy, we have our daily live classes. So, we have our daily live classes. So when you go to a coaching institute, it's very difficult, as you have to get up, get ready. There's a lot of time waste, energy waste. Once you reach there, you have to get a appropriate place to sit, etc. So it is quite time consuming, energy consuming, and not all your doubts can always be cleared, because the educator too is time bound and has to finish a particular amount of syllabus in a particular amount of time, cannot clear everyone's doubts, etc. So at Unacademy, during the class, you can chat with your educator, engage in discussions, and clear your doubts. All this while the class is going on. Now, these are structured courses. All these courses are structured and they are in line with your exam syllabus to help you best prepare for your exam. Then we conduct these live tests and quizzes. So we have these live tests and quizzes that we conduct regularly, and so we conduct live tests and quizzes which will help you all to evaluate your performance, and you all can know where you all stand and how you all are doing. And of course, it's a one subscription which gets you access to all of our live and recorded courses, and you can watch them from the comfort of your home. Now, these are some of our top educators. These are some of our top educators. That is just a second. Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Preeti Sharma. Dr. Nikita Nanwani is also she has she's a NEET PG So Dr. Nikita Nanwani, she's a NEET PG mentor. So she's a NEET PG mentor in NEET PG mentor for radiology as well as mnemonics and concept focusing, and on must-know topics which encompass all subjects. So Dr. Mohammad Azam, Dr. Preeti Sharma, and Dr. Divish Mishra. And these are some of the courses offered on our platform. As you can see, there are various courses that are there to choose from each subject, and these so as you can see, there are various courses to choose from, and um, uh, it's very diverse. And like subjects like anesthesia, psychiatry, radiology, dermatology, you all didn't have to go in detail during your during your MBBS. For NEET PG, you need to know them a bit in detail, because these are a lot of 11 marks each, but these 11 marks are very easy to score if you go into slight detail into these subjects. Because like in MBBS, you didn't have to study in detail. Here too, your questions won't be very detailed as compared to physiology, anatomy, etc., where the questions will be really detailed, because after all, those were subjects that you're studying for a year and all, etc. They are awarded 44 points each subject. These are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, capsule on larynx, course on respiratory system pathology. So coming to NEET PG subscription. So as you can see, there are 5 types of subscriptions on your screen. Those of you who are giving the exam this year, 6 months should be good. For the rest of you, 12 and 24 months, I would highly recommend. 12 months, it's more. 12 and 24 are more economical, as within that stipulated amount of after 6 months, if you all don't clear, you all don't like your subject, you all want to take the exam again, you all will have to subscribe again, pay again. Whereas with 12 and 24 months, that is not the case, as you have the buffer period. Plus this time gives you time to choose what subject you want, to decide on the subject you want, to decide what subject you're like. It does give you that buffer period, that time, because you all will be doing this for the rest of your life, so you all need to enjoy what you all are doing. So do use my code SA. I'm sorry. Do use my code SASHA. SASHA to avail the 10% discount. Now again, 24 months. So after, no harm in dropping 2 years. Nobody is going to ask you how long you took to clear, etc. Don't hesitate. At the end of the day, it is what you love you have to be doing. You should enjoy what you're doing. Nobody will ask you. It's all about practice. Clearing this exam is also about hard work and practice. So please do use my code SASHA. You can avail a 10% discount and subscribe. The discount applies to all the subscriptions. Now the quiz will be started. I will just set the timer. Okay. So your first question is, in a 5 kg child, the end-tidal carbon dioxide tension is 35 mm during spontaneous ventilation through a Mapleson D system. Which single change is most likely to increase this value? So the end-tidal carbon dioxide, the EPCO2, is 35 millimeter of mercury. So which parameter will increase this value? Decreasing the fresh gas flow, increasing respiratory minute volume, opening the pressure release valve, or removing the reservoir bag? So your answer is decreasing the A, decreasing the fresh gas flow. So the ETCO2 is already 35 millimeter of mercury. First of all, in a 5 kg child, the Jackson-Rees circuit has to be used. Right? Jackson JR circuit has to be used. The Mapleson D cannot be used, though the function is similar. So the most to in the EtCO2 will be 35 millimeter of mercury. To increase this further by decreasing the fresh gas flows, there will be more amount of rebreathing and increase in the end-tidal carbon dioxide. So next question. An anesthesia machine is set to deliver oxygen 2 liter per minute, nitrous oxide 2 liter per minute, and sevoflurane. After 30 minutes of stable anesthesia, which of the following is most likely to cause a decrease in oxygen analyzer reading from 50 to 30%? So what do you think? So the oxygen analyzer is analyzing the oxygen reading. What do you think could have caused this decrease? A leak in the ventilator bellows, accumulation of water on oxygen sensor membrane, calibration at 100% oxygen using less than 100% oxygen, disconnection of the wall oxygen hose. So your answer to this question is accumulation of water on the oxygen sensor membrane. So there is stable anesthesia and suddenly there is a decrease in the oxygen analyzer reading. So water vapor causes a lot of erroneous readings with the devices. So it should be suspected first that maybe because of the water vapor that collected on the water vapor that collected, that could have been the probable cause for the erroneous reading. A 27-month-old 14 kg infant with intestinal obstruction is anesthetized with nitrous oxide at 1 liter per minute oxygen. Nitrous oxide at 1 liter per minute, oxygen at 0.4 liter per minute, and halothane at 0.8% using a Baines circuit. Ventilation is controlled at a rate of 30 per minute. The child's temperature is 39 and PaCO2 is 65. Which of the following is most likely? Malignant hypothermia, low gas inflow rate, low respiratory rate, or pulmonary aspiration of gastric contents? So, yes, malignant hypothermia does sound very tempting, right? But it is low gas inflow rate. So, we do not have adequate information to know that it is malignant hypothermia. I mean, it's a 14 kg infant, fine. We do not have any family history. We do not know where the patient is coming from. So we cannot really, and this is the first time that the patient is being exposed to halothane. So we do not really know unless we have the family history and all. We cannot say it is malignant hypothermia, right? Because yes, exposure to halothane and all does is a risk factor to trigger malignant hypothermia, but we need to have some family history with this infant, knowing that something has to be there. So the most likely cause we could suspect would be a low gas inflow rate for this high rise in PaCO2, right? And children temperature 39 is high, I do agree, but still the most likely cause of this capnographic tracing obtained just after laryngoscopy and intubation is? Esophageal intubation, partial obstruction of the endotracheal tube, pulmonary embolus, insertion of an endotracheal gastric tube, nasogastric tube, or mild bronchospasm. So your answer is esophageal intubation. Okay. So during pre-oxygenation, prior to laryngoscopy and intubation, pre-oxygenation with bag mask ventilation, some amount of air or oxygen would have passed into the stomach. So while intubating with the tube in place, the capnographic initial reading will be normal, followed by a decrease like this. So this indicate initial might be normal because of the oxygen that is present within the stomach. So during general anesthesia administered through circle system, the soda lime absorbent is exhausted. No fresh soda lime is available for use. Which of the following is the most appropriate next step to prevent hypercapnia in this patient? Circle system is your anesthesia ventilator, the tubings and all. So your answer is increasing the fresh gas flow. So how do you prevent hypercapnia? Soda lime is exhausted. So basically to flush it all out, the fresh gas flow should be increased. Okay, it has nothing to do with increasing the tidal volume of the patient or discontinuing nitrous oxide. Increasing tidal volume will not help the patient to anesthetize. Okay, the soda lime is exhausted. So to flush out all that carbon dioxide, you increase the fresh gas flows. A 55-year-old man is undergoing craniotomy in the sitting position. Mean arterial pressure is 75 millimeter of mercury. Arterial blood gas values are PaCO2 of 41 millimeter of mercury. pH of 7.37. EtCO2 is 7 millimeter of mercury. Which of the following is the most likely cause of the increased PaCO2 to the PEtCO2 gradient? Arterial carbon dioxide to the EtCO2 gradient. So 55-year-old man undergoing craniotomy in sitting position. Arterial pressure is 75. Blood gas value is 41. pH 7.3. EtCO2 is 7. Why is there this discrepancy? So the answer is partial disconnection of the capnography sampling tube. Now the capnography sampling tube measures your end-tidal carbon dioxide. So the, the, the arterial carbon dioxide is 41 and your pH is within normal limits. Your end-tidal carbon dioxide is less. So what could be the reason? It cannot be endobronchial. It cannot be the decreased cardiac output because the PaCO2 would have changed. Endobronchial intubation will not give you a decreased PtCO2. Hyperinflation of lungs would have given, both values would have changed, and venous air embolism, again PaCO2 would have changed. So it is partial disconnect of the capnography sampling tube is causing the low PtCO2. Now, which Mapleson breathing circuit shown in the illustration permits the least amount of fresh gas inflow to prevent rebreathing during spontaneous ventilation? So your answer is Mapleson A. So for spontaneous ventilation, Mapleson A is the best for spontaneous ventilation because it requires least amount of fresh gas flow to prevent rebreathing. Whereas Mapleson D is the best for controlled ventilation. As again, it uses lesser fresh gas flows. During attempted cannulation of the right internal jugular vein, the exploring needle goes lateral to the vein. Which of the following structures is most likely to be encountered? Right internal jugular vein, exploring needle goes lateral to the vein. Your answer is Pacho phrenic nerve. So the carotid artery lies median to the internal jugular vein. The vagus nerve does not come in the area. The thoracic duct lies on the left side, not on the right side. So it is your phrenic nerve which lies lateral to your internal jugular vein. A healthy patient is receiving general endotracheal anesthesia with nitrous oxide 4 liter per minute, oxygen 2 liter per minute, and isoflurane 1% with spontaneous ventilation. The inspiratory breathing hose becomes disconnected from the inspiratory valve. The earliest alarm that will be produced will be by, so the pulse oximeter with finger probe set to alarm at 60% saturation, a mass spectrometer set to alarm when no breath is detected for 30 seconds, an oxygen analyzer mounted on the inspiratory valve outlet and set to alarm at 25% oxygen concentration, or a capnograph sensor at the Y piece that alarms when EtCO2 tension is greater than 60 millimeter of mercury. That's a mistake there. Yes, so the first thing to alarm, the earliest alarm will be produced by a capnograph. So your EtCO2, as soon as there is any disconnection in the inspiratory or expiratory hoses that connect to the patient from the machine, the capnography, that is your end-tidal carbon dioxide monitoring, will become a flat line, and because there is disconnection, and it will be the first monitor to alarm. Your oxygen analyzer to fall to 25% concentration and all will take some time. Pulse oximetry also takes a time. There is at least a 15-second delay before it detects, whereas capnography is immediate. Of course, a capnograph is set to alarm at about 50 to 60 millimeter of mercury. The vapor pressure of volatile anesthetics depends on. So your answer is temperature. Vapor pressure depends only on temperature, not on pressure, not on ambient pressure or volume of the system. It depends only on temperature. Following antagonism of a non-depolarizing muscle relaxant with neostigmine, which height is normal? Okay. To achieve this effect, the percentage of acetylcholine receptor pool that must be free of muscle relaxant is. So your answer is 25%. So to achieve percentage of acetylcholine receptors that must be free of muscle relaxant is 25%. Which of the following is most effective in preventing intraoperative hypothermia in adults? So the answer is very simple. Nothing fancy has to be done. Just maintaining a warm operative room, keeping the patient warm, covering the patient well. That's all is needed to prevent, is which is the most effective in preventing intraoperative hypothermia. But of course, maintaining a warm operative room is really not possible because it is very difficult for the surgeons to operate. So the operating room temperatures are usually quite cold. That's when we use all this heating and humidifying, circulating warming mattress, etc. But otherwise, maintaining a warm operative room is the most effective method. Each of the following factors may lead to erroneous readings using pulse oximeter, except the answer is intravenous dyes. So intravenous dyes will have no effect on the pulse oximeter. It's basically the oxygen saturation in the blood that the pulse oximeter detects. So electrocautery will change, has an influence. High cardiac output states will have an erroneous reading. Infrared lights near the sensor also will change, and severe hemodilution does have an effect. Compared with the semi-closed circuit system, a closed system, what is the advantage of the closed system over the semi-closed circuit system? Yes. The answer is permits calculation of oxygen consumption. So, over a semi-closed circle, a closed circle system permits calculation of oxygen consumption. Which of the following detects the smallest volume of venous air embolization? Which which of these cardiac monitors is most sensitive and specific? So, your answer will be the precordial ultrasound signal detects any change in the, so basically Doppler ultrasound detects even the smallest volume of venous air embolization. If the low pressure alarm of an anesthesia circuit is broken, which of the following monitors will provide the earliest indication of a disconnected ventilator hose? Answer by now you should have gotten it. It is yes. So infrared capnograph. Again, disconnected ventilator hose, immediately the capnography monitoring will fall to 0 and it will alarm. During anesthesia using a Bain circuit, PaCO2 is independent of minute volume if fresh gas flow is greater than 17 ml per kg. PaCO2 is independent of fresh gas flow if minute volume is greater than 100 ml per kg. PaCO2 may be normal in the presence of rebreathing. Carbon dioxide removal is more efficient during spontaneous ventilation than controlled ventilation. The answer is 4. So it is more efficient carbon because the patient is breathing spontaneously, so it is more efficient. Which of the following statements concerning monitoring of neuromuscular function during general anesthesia is true? Facial nerve electrodes underestimate recovery from block compared with ulnar nerve electrodes. More current is required to depolarize a nerve beneath the negative electrode than beneath the positive. Needle electrode should be electrically grounded. Supramaximal voltage is 10% higher than the voltage required to elicit pain in the awake. And the amount of neuromuscular block is underestimated if electrodes are placed on paretic limb. So your answer is the amount of neuromuscular block is underestimated if the electrodes are placed on a paretic limb. So there will be underestimation. Of course, the paretic limb is paralyzed, so the block can be underestimated. Facial nerve electrodes Do not underestimate recovery from block as compared with ulnar nerve. More current is not required to produce a nerve. There is no such thing. And needle electrodes need not be electrically grounded. And supramaximal voltage is about 50% higher than the voltage required to elicit pain in the awake patient. The principal rationale for the use of warm, humidified, inspired anesthetic gases in children is the answer is to prevent dehydration. A healthy 18-year-old 65 kg woman undergoing diagnostic laparoscopy is being monitored with a properly functioning and calibrated capnograph. The EtCO2 concentration is 6% and the inspired carbon dioxide concentration is 1%. This may be caused by each of the following except malfunctioning of the expiratory valve in the Bain's circle system, low gas inflow with the Bain's circuit, exhausted soda line within a circle system, absorption of carbon dioxide from carbon dioxide laparoscopy. So, all from absorption of carbon dioxide from carbon dioxide laparoscopy. Okay, it may be caused by each of the following except by absorption of carbon dioxide from carbon dioxide laparoscopy. That time the entitled carbon dioxide will be much higher even with an inspired concentration of 1%. So if there was also absorption of carbon dioxide laparoscopy, the concentration of EtCO2 would be high, not so low. Yes, malfunctioning of an expiratory valve, low gas inflow and exhausted soda line. A 32-year-old woman is anesthetized for suboccipital craniotomy. During positioning, the capnograph showed an abrupt increase in the slope of the expiratory upstroke. Which of the following is most likely? Oh, sorry. So the answer is so basically what they are talking about is this is the normal EtCO2 curve. This is normal. So here they are saying is during positioning. So first of all, there's a clue there. During positioning, there is an abrupt increase in the upstroke. So this is your shark fin pattern. This is the expiratory phase, right? This is the shark fin pattern and usually seen with some obstruction that is occurring. First obstruction should be suspected should be the machine more than anything. So kinked endotracheal tube would be your first choice to look for. The Bain circuit provides nearly identical delivered and inspired anesthetic concentrations, has the fresh gas flow inlet near the reservoir bag, is a non-rebreathing circuit at any fresh gas flow rate, and is the most efficient during spontaneous ventilation, has a time constant greater than 1 minute for change in inspired anesthetic concentration. So the answer is provides nearly identical delivered and inspired anesthetic concentration. So what is inspired and what is delivered is almost identical. The fresh gas flow inlet is near the patient end, not the reservoir bag. The reservoir bag is away from the patient end. This is a non-rebreathing circuit, not at any fresh gas flow. At low fresh gas flow rates, it causes rebreathing. It is most efficient during controlled ventilation, not during spontaneous. During spontaneous, so during controlled, it is most efficient. Non-rebreathing at high fresh gas flow rates has a time constant greater than 1 minute for change in inspired anesthetic concentrations. No, that is not true. After the removal of the electrocautery pad from the thigh, a burn is noted at the site. Which of the following is most likely contributed to this injury? So your answer is dried gel on the electrocautery pad. So the dried gel on the electrocautery pad contributed to this burn. So there has to be, the gel should be adequate and it should be adequately placed on the patient to prevent any burn. Which of the following is a characteristic of the Bain's breathing circuit? Condensation of moisture in inspired gases is facilitated by the circuit design. Fresh gas flow coaxially around the exhalation ring. Fresh gas flow need not exceed minute ventilation. The circuit eliminates the possibility of rebreathing, and the circuit is functionally similar to Jackson-Rees system. Which of the following is a characteristic of Bale's circuit? The answer is the circuit is functionally similar to Jackson-Rees. So condensation of moisture and inspired gases is not facilitated by the circuit. It is not facilitated by the circuit. Fresh gas flows coaxially around the inhalation in. Fresh gas flow it needs to exceed minute ventilation. Uh, the circuit eliminates, for controlled ventilation, the circuit eliminates the possibility of rebreathing. No, there is rebreathing is still present, but yes, the circuit is functionally similar to Jackson-Rees system. The accuracy of oxyhemoglobin saturation determined by digital pulse oximeter is affected significantly by each of the following except. Yes, so your answer is isovolumic hemodilution of hematocrit of 20%. It is an isovolumic hemodilution. There will be no effect of this. There will be no effect on the pulse oximeter. So there is movement of the patient, position of the operating room light, intravenous administration of methylene blue, and infusion of phenylephrine will affect. Which Mapleson breathing circuit permits the least amount of fresh gas inflow to prevent rebreathing during spontaneous ventilation? Of course, this is a repetition kind of question, but it's framed in a different way. Mapleson A is the best for spontaneous ventilation to prevent anything. A burn, sorry, a burn, a burn is found at the site of the electrocautery pad. Which of the following is most likely? The electrocautery pad became partially detached, right? The electrocautery pad should be fixed properly on the patient and the jelly should be adequate to prevent any burns. Pulse oximetry accurately reflects SaO2 in which of the following situations? So 40% hemoglobin concentration. Yeah, so pulse oximetry will reflect a correct SaO2 even with 40% hemoglobin concentration. However, the indocyanine, green, methylene, low carboxy hemoglobin, it will reflect a different SaO2. The capnographic tracing is from a 2-month-old infant anesthetized using a pediatric circle system and a mask at a fresh gas flow of 4 liters per minute. The sampling port is at the elbow connector. This tracing indicates so this tracing actually indicates rebreathing, which is a mixture of inspired and expired gases. Which of the following statements concerning the use of vein circuit is true? So the correct answer is the concentration of inspired vapors can be changed rapidly, right? So in the previous question, it is rebreathing because it is, as I'm sorry, I forgot to tell you this, it is not touching the baseline. That is rebreathing, mixing of inspired and expired gases. The answer for this question is the concentration of inspired vapors can be changed rapidly with Bean's circuit. Okay. Fresh gas flow cannot be as low as patients, it has to be higher. Heat conservation is not better than the circle system. Low flows cannot be used with controlled ventilation. Higher flows have to be used, and it cannot use lower flows than with the Jackson Rees. A 55-year-old man is undergoing craniotomy in sitting position. Mean arterial pressure is 75. Arterial blood values are PaCO2 41 and pH of 7.37. EtCO2 is 7 millimeter of mercury, entitled carbon dioxide. Which of the following is the most likely cause for the increased PaCO2 to EtCO2 gradient? I'm sorry, we've already completed this question. This is a repeat question. This is of course a partial disconnection, my bad. The pin index system is not used in central pipeline connections, requires aligning 4 pins with 4 holes, is used on all sizes of medical gas cylinders, has been replaced by color coding of gas cylinders, prevents overfilling of gas cylinders. Which is true. The pin index system is a safety mechanism seen in cylinders, gas cylinders. It cannot be used in central pipeline connections. It requires, it can be more than 4 also. 4 pins in 4 holes is not a thing. It can be 1 pin to 1 hole or 7 pins to 7 holes. It's nothing 4 pins to 4 holes. There is no such ratio. It is not used on all sides. It is only used in E-type cylinders. It has been replaced by color coding. No, this has actually replaced color coding of cylinders, and it does not prevent overfilling of cylinders. It just prevents cylinders of being fixed to the wrong place. During spontaneous ventilation, the APL valve is kept fully closed. Partially closed with partial closing will result in PEEP, pressure less than 1 centimeter of water. Which statement is false among these? Which is a false statement? So your answer is the valve is kept fully open during spontaneous ventilation. Partial closing results in PEEP. Pressure less than 1 centimeter of water is needed to open the valve and should have pressure drop 1 to 3 centimeter of water for airflow of 3 liter per minute and 1 to 5 centimeter of water at 30 liter per minute. For controlled ventilation, the order of efficiency is So the order of efficiency is D, B, C, A. Mapleson D is more efficient than Mapleson B, is more efficient than Mapleson C, is more efficient than Mapleson A. Mapleson A is least efficient for controlled ventilation, most efficient for spontaneous ventilation. All are true about lax modification except. So lax system is actually coaxial Mapleson A system, not Mapleson D. Westminster face piece is also known as. So it is also known as Mapleson C. All are advantages of Bain's circuit except lightweight, convenient to use, scavenging of exhaled gases is not facilitated. Exhaled gases in the outer tubing add warmth to the inspired gases. So the answer is scavenging of exhaled gases is facilitated. There is scavenging. Ethics test is used for Mapleson. Mapleson D. Ethics test is Mapleson D. So that was the quiz for today, guys. If you enjoyed the class, do subscribe. Use my code SASHA to get a 10% discount. See you soon for our next class due tomorrow.